Bismillah ar-Rahman ar-Rahim. This is our third pathology lecture in the cardiovascular system. It will be about veins and lymphatics. Before going into the contents of the lecture, this is only a quick revision of the normal histology of the blood vessel. As we have learned before, there are three layers within the wall of any blood vessel, and these are the intima, the media, and the adventitia. The intima is composed of endothelial cells and a very thin layer of connective tissue, and is bordered by the internal elastic lamina. The second layer is the media, which is composed mainly of smooth muscle fibers, and in some particular types of blood vessels we have elastic fibers as well. It is bordered from outside by the external elastic lamina, and then we have the adventitia, where we have connective tissue, fibroblasts, and some smaller sized blood vessels that give nourishment to the blood vessel wall, and these are called vasa vasorum. Moving into the next picture, we have here, this is a microscopic picture showing us an artery and an adjacent vein. A represents the artery and B represents the vein, and you can notice that we have certain differences between veins and arteries. Arteries have thicker wall, they look more rounded, more rigid, and the vein, on the other hand, has a thin wall that does not have well-developed media, and that's why it's easy to see the vein looking like this. We mean by that it looks collapsed. So arteries look like rigid pipes, while veins tend to be collapsed. They have low intraluminal pressure, and they have thin walls without a good amount of smooth muscles in the media. That's why they look this way. So we can understand from this picture that it's easy to compress veins. It's easy to collapse veins and to change the shape of the vein. Another diagram for comparison between arteries and veins. Points of similarity between arteries and veins are the presence of the three different layers within their walls. Endothelial cells, which is within the intima, media, containing the smooth muscles, and the adventitia. But the major difference between veins and arteries is quite obvious, as you can see, which is within the media layer. The medial layer of the artery is much thicker and stronger than that of the vein. Normal vein physiology. Before going into pathologies of veins, we need to understand what is the normal vein physiology. So veins in general, especially large veins of the lower limbs, contain these structures from inside. These are called pocket valves. These pocket valves are found inside the vein, and they help the vein in its function to return the blood from tissues towards the heart within the venous blood flow. This is the natural or the physiological movement of those pocket valves. So as you can see, those pocket valves, they work as one direction valves. They let or allow the blood to move in only one direction, which is towards the heart, outside of tissues and towards the heart. What about these arrows from right and left sides? These represent the help that the vein gets from the surrounding structures in performing its normal physiological function in returning the venous blood towards the heart. And these arrows represent the function of the surrounding skeletal muscles. So this effect, which is sometimes called milking effect or squeezing effect from the skeletal muscles surrounding the veins, helps the veins in its in maintaining its normal physiological function. So now let's imagine that there is something wrong with these pocket valves, or something is wrong with the surrounding skeletal muscles. For example, the pocket valves are congenitally abnormal. They have shortening or rolling or deformities, or the surrounding skeletal muscles are weak for some reason. Another problem that might also happen is the intraluminal pressure. If the intraluminal pressure within the vein increases for some reason, this might lead to a pathological process called varicose veins. So varicose veins are abnormally dilated and tortuous veins that are produced by prolonged increase in intraluminal pressure and loss of the vein wall support. The most common location of those varicose veins are the superficial veins of the leg. So these are typically involved. In this picture, taken from the same patient, so this is the leg of the patient, posterior to the neck, and this is the same leg, but this time the picture is taken 2 hours following standing. As you can see, the major difference between both pictures is the presence of those tortuous and dilated bluish vessels under the skin, and these are the varicose veins. Symptoms of varicose veins, they vary from patient to another, and they can vary according to the location and the severity of the condition, and they include venous stasis, edema of the affected limb, simple orthostatic edema, and of course the cosmetic effect of this problem, which is a major complaint in some patients. This condition is quite common. It can affect up to 20% of adult males and even more than 30% of adult females. Risk factors for lower limb varicose veins include obesity, female gender, pregnancy, and family history. So some families are known to develop premature varicosities because of the imperfect venous wall development. If we take a vein that is involved by varicosities and look at it under the microscope, we might see the following findings: vein wall thinning, intimal fibrosis within adjacent segments. We could also see some spotty medial calcifications, or what we call phlebosclerosis. Sometimes those varicosities might develop intraluminal thrombosis, and in cases where there are some congenital components of the problem, we might see venous valve deformities like rolling and shortening. Complications of varicose veins, they include stasis, congestion, edema, pain, and thrombosis in some cases. Chronic varicose ulcers, we mean by that development of skin ulcers overlying the site of the varicosities. This is usually the case in patients with comorbidities and other vascular problems and who have the varicose veins for prolonged periods of time. Now, embolism from this kind of problem, which is varicose veins, is extremely rare. So this is not a major problem in superficial veins that develop varicosities. Another problem that affects veins, this is a very important condition that you need to understand and to know some information about. We call this disease thrombophllebitis or phlebothrombosis. So both terms are in fact interchangeable. They mean the same thing. Phlebothrombosis means, phlebo comes from the word vein, thrombosis means formation of thrombus inside the vein. Thrombophllebitis, we mean by that thrombosis, and the suffix itis, it means inflammation in the venous wall. So we have two processes that happen inside the vein: inflammation and thrombus formation. Which process happens first? This is questionable and controversial. Some people say that the thrombosis starts first, and this thrombosis will elicit or trigger inflammation of the wall, while others say that inflammation is the trigger that leads to the thrombus formation. This condition is quite common, and the most common site affected is the deep leg veins. More than 90% of all cases are seen within the deep leg veins. Predisposing factors for thrombophlebitis include congestive heart failure, neoplasia, pregnancy, obesity, the post-operative state, and prolonged bed rest or immobilization. And as you can see, all of these factors have been discussed before in the first lecture, in our first lecture, when we talked about risk factors for venous stasis or for blood stasis or abnormal blood flow. So anything that leads to blood stasis, especially in the venous side of the circulation, might be or might act as a risk factor for development of thrombophlebitis. The clinical manifestations of thrombophlebitis are variable, and they include local as well as systemic manifestations. The local manifestations of thrombophlebitis include distal edema, distal to the side of the occlusion, of course, cyanosis of the affected limb, superficial vein dilation because of the backflow of blood towards those veins, the feeling of heat, tenderness, and the presence of redness, swelling, and pain. Thrombophlebitis of the upper limb veins is not quite common, and when it's present is usually associated with some local risk factors. For example, the use of a catheter or a cannula. In rare cases, it can be associated with systemic hypercoagulability syndromes. Now, we are going to discuss some brief information about some special types of thrombophlebitis. These thrombophlebitis syndromes are quite important because they might be a mark for an underlying significant disease. The first syndrome is called migratory thrombophlebitis, which is also known as Trousseau sign. In this condition, the patient develops hypercoagulability because of an underlying tumor. So this is a paraneoplastic syndrome that is related to a tumor that elaborates procoagulant factors. We mean by that the patient is having some sort of cancer, for example, colon cancer, pancreatic cancer, stomach cancer, or any type. And this cancer, as a paraneoplastic syndrome, releases into the circulation a substance that works as a procoagulant factor. This will lead to the production of migratory thrombophlebitis. We mean by that the patient will develop multiple areas of thrombophlebitis involving his extremities, involving the abdomen or internal organs, and these thrombophlebitis events will have a migratory pattern of occurrence. We mean by that there will be some time lapse between the attacks. Another important type of thrombophlebitis syndromes is called the superior vena cava syndrome. Superior vena cava, as you know, receives the venous blood back from the head, neck, and upper limbs and the upper part of the chest and returns it into the heart. This syndrome is usually caused by neoplasms that either compress or invade the superior vena cava. Most common cancers that can produce this disease is lung cancer. The syndrome will manifest by marked dilation of the veins of head, neck, and arms with cyanosis, as we can see in this picture. So this patient who has lung tumor that is obstructing his superior vena cava, this will lead to backflow of the venous blood towards the organs that were drained by the superior vena cava, which are the head and neck, the shoulders, upper limbs, and the upper chest. So the patient will complain of facial edema, plethora, and congestion and distension of the veins distal to the obstruction, and we can see those as distended and dilated veins of the upper limbs and shoulders and upper chest, along with cyanosis and edema of those organs. A third syndrome is called inferior vena cava syndrome. This is usually caused by neoplasms that either compress or invade the inferior vena cava. Most commonly, we are describing a hepatocellular carcinoma coming from the liver or a renal cell carcinoma within the kidney. These tumors are famous for having a striking tendency to grow within veins. The patient will develop marked lower extremity edema, distension of the superficial collateral veins of the lower abdomen, or what we call the Mendoza head. Moving into some selected topics within the pathology of lymphatics, we will be very briefly discussing the following: lymphedema, lymphangitis, and chylous. Starting with lymphedema, we mean by that the presence of edema that is the result of lymph. As you all know, the lymphatics in our body helps to return a part of the interstitial fluid from tissues back into the venous blood, and from there it will go back to the heart. So the function of the lymphatic system is to return the extra interstitial fluid and to help in the venous return to the heart. Now, if for some reason one of those lymphatics is obstructed, this means that the interstitial fluid will accumulate within the tissues distal to the site of the blockage. With time, this will lead to swelling and inflammation of the tissues below the level of the obstruction, leading to the formation of lymphedema. Lymphedema in general can occur as either a primary problem or a secondary problem. Primary lymphedema is usually congenital in pathogenesis and is usually the result of lymphatic agenesis or hypoplasia. We mean by that either the lymphatic in a certain location in the body is completely absent or it's hypoplastic, so it's underdeveloped. Congenital or primary lymphedema usually manifests early in life during childhood. Secondary lymphedema, which is much more common than primary or congenital lymphedema, is usually obstructive in nature, meaning that there is some sort of blockage of a previously normal lymphatic vessel. Examples of causes that might lead to obstructive or secondary lymphedema include malignant tumors, surgical procedures that remove lymph nodes, for example, the surgical procedure that is used to treat breast cancer. Breast cancer treatment includes mastectomy, removal of the tumor and the breast tissue, plus removal of the ipsilateral axillary lymph nodes. Post-radiation, fibrosis at the site of the affected lymphatic. Filariasis, which is a parasitic infection that leads to inflammation, destruction, and occlusion of the lymphatic vessels within the affected limb. Anything that leads to inflammation with the associated post-inflammatory thrombosis and scarring at the site of the previous inflammation. This is a picture showing lymphedema. So this is the normal limb here, and this is the abnormal or the affected limb by lymphedema. As you can see, huge distension and swelling of the affected limb. The second condition that we are going to discuss within the subject of lymphatics is lymphangitis. Lymphangitis, this word contains the suffix itis, which means inflammation. ANG here means vessel, so this condition refers to inflammation lymphatic vessel. Almost always this inflammation is related to an infection by a bacterial microorganism that spreads into lymphatics. Most common offending microorganisms are group A beta hemolytic streptococci. Because of the inflammation, the affected lymphatics will become dilated, filled with an exudate of neutrophils and monocytes. The affected site would show redness and painful subcutaneous streaks, which represent the inflamed lymphatics. This might be also associated with painful enlargement and swelling of the draining lymph nodes, which is called acute lymphadenitis. Rarely, subsequent passage of this inflammation into the venous circulation might result in bacteremia or sepsis, especially in immunocompromised patients. The last subject of this lecture is chylous. Chylous is milky accumulation of lymph in various body cavities. So in this condition, the accumulation of lymph does not happen within the interstitial spaces of tissues. It happens within body cavities. We have 3 body cavities, as you know, that might develop lymphatic accumulations, and those are the pleural cavity, the pericardium, and the peritoneum. The most important mechanism of development of chylous is rupture of dilated lymphatics that are typically obstructed secondary to tumors. Types of chylous, this depends on the location of the chylous accumulation. So we either have chylous ascites in case this accumulation happens within the peritoneal cavity, or we have chylothorax if this accumulation happens within the pleural cavity or the chest. Chylopericardium is the chylous that accumulates within the pericardium. Why is it called chylous? The word chylous comes from the milky appearance, color, and consistency of the accumulated fluid.